So I'll talk about the rotator cable. I have no disclosures. First, a couple of years ago, my family and I traveled to Costa Rica, and we saw two things which I thought were somewhat pertinent to our talk. One was the slough here, and the other were the hanging bridges. But first, I'd like to pose a question here. The question is, when we scan asymptomatic shoulders, we find high prevalence of tendinosis, about 40% in individuals, and more surprisingly, high prevalence of tendon tears, about 25% in the general population, more so in older, and more so in older individuals. And the question is really, when and why do symptoms occur in the context of tendon tears in the shoulder? Why are some people asymptomatic with big old tendon tears? Think of it, and we'll get back to it at the end of the talk, and I'll propose a theory. Getting back to our friend the slough, it's an unusual creature really. It characterizes upside down, and it's got a tensile loading regimen on its shoulder rather than a compressile one. And when we scan the shoulder of the slough, we find that the clavicle articulates with the acromial-coracoid arch, but doesn't articulate the sternum at all, and this allows great range of motion, which he needs for his upside-down life. Now, when we look at our shoulder, it's also undergone great development as well. Great range of motion, great degree of anterior flexion, allows us to pitch a ball or to become more dangerous hunters. And why is that so? When you look at the anatomy, the rotator cuff muscles and tendons around that humerus are not unique. We have something very similar in the hip itself. But when we look at the bone, the glenoid is pretty shallow, allowing for a great degree of motion. Okay? In addition, there are soft tissue modifications. Professor Steinbach talked about the labrum and so on, and I'll talk about the rotator intervals and the cable, which also play a part in the stability of the shoulder, stress dispersal, and stress shielding. So let's start with the anterior rotator interval, which fulfills the roles in the biomechanics of shoulder stability and long hip biceps tendon stability. When the supraspinatus and subscapularis diverge around the coracoid itself, they form a space, a triangular space devoid of tendons, covered by connective tissue, which is focally thickened in some areas, and these are the ligaments, and specifically two ligaments, the coracohumeral ligament, CHL, and superior glenohumeral ligament, and also the rotator cable, which starts in this area. And in addition, you have the the long hip biceps tendon coursing through the interval from its origin to the bicipital groove. So these are the structures we're going to talk about in the anterior rotator interval. Now, on MR orthography, we can see the structures in the very well. Here's a sagittal and an axial MR orthogram. You can see the ligaments we'll talk about shortly. You can see the dimensions of the interval, and that is the go-to imaging modality when we look at the interval itself, the anterior interval. The first ligament we'll talk about is the coracohumeral ligament, the CHL. It arises from the lateral aspect of the coracoid. It basically is inseparable from the overlying capsule, and it attaches distally, forming two bands, the medial and the lateral band. We'll talk about this later. So here we have a coronal T1 weighted sequence. You can see the coracoid here. Here's the coracohumeral ligament. Axial MR arthrogram, coracoid, coracohumeral ligament, inseparable from the capsule. And here's a sagittal T weighted sequence, anterior, posterior. Here's the supraspinatus, subscapularis. The area devoid of tendon here is the interval, and this is the capsule with the coracohumeral ligament and the biceps deep to it. The next ligament is the superior glenohumeral ligament. It's a variably expressed structure. It arises from the supraglenoid tuberosity or from the labrum, and it has variable descriptions distally, either to the lesser tuberosity, to the bicipital groove floor, or merging over the groove with the coracohumeral ligament. And here are axial and sagittal MR orthograms. You see contrast in the joint, anterior and posterior. You can see this is the superior glenohumeral ligament here, arising from the labrum and supraglenoid tuberosity. Sagittal image, you can see the close association of the SCHL with the biceps, and finally far laterally, its attachment. We'll talk about this area. It's called a pulley in a little while. Now, the question you're asking yourself probably is, why should we bother? Does it have any clinical importance, these two ligaments in the capsule? It's been shown that the rotator interval plays a role in maintaining that stability we have in the glenohumeral joint between the great range of motion and instability. Pathology in the rotator interval can manifest as instability, or the other end of the spectrum, as loss in the range of motion or adhesive capsulitis, and we'll be talking about these two areas as well. Now, rotator interval lesions, injury, can appear, manifest on arthroscopy and histology as inflammation of these tissues, the capsule ligaments, contraction of the coracohumeral ligament and the capsule as well, and finally fracture defects, holes, or widening of that interval, which can be appreciated in arthroscopy and MR arthrogram. You can see the inflamed tissue in the patient with a rotator interval lesion compared to the normal interval from a posterior portal from an arthroscopy. So, glenohumeral instability, the glenohumeral joint may be associated with rotator interval lesions, capsule and ligamentous lesions, including incompetence or laxity of the ligaments, fracture defects or tears. And these could occur in the context of acute injury, repetitive microtrauma, or a combination of both. Okay? On MR arthrography, these ligaments, when they are injured, can appear thick and irregular. So here's an axial MR arthrogram. You can see this is the normal SDHL here. Here's a thickened abnormal SDHL in a patient with instability. This was surgically proven. The SDHL or the ligaments in jello can appear attenuated. You see how thin this ligament is compared to a normal one here. They can appear irregular and nodular. So this is a coronal T1 weighted sequence, and you can see the coracoid here. This is the coracohumeral ligament. You see how irregular and nodular it looks compared to the normal taut one in this area here. And finally, oftentimes we'll see fracture defects, holes in the interval itself in place of the capsule. Here's a sagittal MR arthrogram, contrast in the joint, oozing out of the joint, and this is a young patient with instability, no labral pathology, no other ligamentous pathology. This was fixed and she was stable following the surgery. So frank rotator interval defect compared to the normal interval where the capsule and the ligaments hold the contrast in place. Finally, sometimes we can see widening of that rotator interval on arthrogram. Here's a sagittal T1 weighted arthrogram. Here's the supraspinatus subscapularis. This distance is increased. I find this difficult. It's very subjective, although there are measurements out there. I typically eyeball this and get a sense of how wide this is, but it's been described, it's out there, and I thought I'd present it. Now, we can also appreciate rotator interval lesion and tears on ultrasound at times. This is short axis ultrasound. This is anterior, this is posterior. Here we have the supraspinatus tendon with a focal full thickness defect filled by bursa, extending to the interval over the biceps tendon. Here's a arthroscopy image, bursal sided view. You can see that cuff tear extending to the interval, uncovering that biceps tendon as well. So we can see this on an ultrasound as well at times. When we have glenohumeral instability, repair of the capsule ligaments is really controversial. Some orthopedic surgeons advocate closure of the interval defects as an isolated procedure. Some will advocate closing the defect and repairing the repair at the same time, and repairing the labrum at the same time. And some surgical and orthopedic surgeons will say no rotator interval treatment is needed. And in my institute, we don't repair these, but I'm sure there'll come a time where we'll repair these as well. At the other end of the spectrum, we talk about rotator interval lesions is adhesive capsulitis with limited range of motion rather than instability. This is typically accompanied by pain. It can occur in 2 to 3% of the population. It could be idiopathic or associated with systemic diseases, trauma, diabetes, and so on. What we typically see on histology and in arthroscopy is thickening of the capsule ligamentous structures, hyperplastic synovitis, and hypervascularity, and various MR sequences target various manifestations of this adhesive capsulitis. So here's a sagittal MR arthrogram, contrast in the joint. Here's a thickened ligament and capsule, corresponding ultrasound, the same thickening of the capsule here. This was basically removed at surgery in the context of adhesive capsulitis. And again, another example of adhesive capsulitis, this is a T1 weighted sagittal sequence, anterior and posterior. The normal fat signal expected in the interval has been replaced by this hyperplastic tissue. On T2 weighted sequence, you can see increased T2 here as well, which could represent hypervascular nature of this tissue. So this is a common phenomenon we see on MR in the context of adhesive capsulitis. And finally, there's also contracture of the capsule ligaments. So on MR arthrogram, we can see contracture of the joint itself. In this case, there's contracture of the axial recess in the context of adhesive capsulitis. This could also affect the bicipital groove and the bicipital tendon sheath. When it comes to adhesive capsulitis and treatment, first, it's conservative, it's physiotherapy. If this doesn't help, we can attempt a Brismont procedure. It's an arthrogram. We inject into the joint, attempting to rupture the capsular ligaments. There's also manipulation under anesthesia. And finally, there's also release of contractures in surgery, arthroscopy, trying to regain that motion we've lost in the shoulder as well. These are all treatments for adhesive capsulitis. Okay. Now I mentioned another structure running through the rotator interval, that is the long hip biceps tendon. We're not really sure what this structure does. Is it really needed? Does it stabilize the shoulder? Is it a weak abductor and so on? Here you can see an arthroscopic image. You can see the biceps tendon. The background is the rotator interval. The foreground is the humeral head. It courses from the supraglenoid tuberosity area through the interval to the bicep groove. As it approaches the bicep groove, it's enveloped by a sling-like structure of tissues that is the biceps pulley, which is a coalescence of ligaments, the thoracohumeral ligament, the superior glenohumeral ligament, and portions of the subscapularis, and maybe even the supraspinatus tendon. They all form this sling-like structure called the pulley, and I'll talk about this shortly. Now, the biceps, really, the long hip biceps tendon has got an unusual course. When you look at it, it's got a sharp angle turn right here. Therefore, it's subject to a lot of mechanical stress, and of course, it's heavily innervated. Not surprisingly, it's known to be an anterior pain generator in the shoulder. Now, unfortunately, from a clinical perspective, diagnosing it is difficult. Its symptoms are not specific: snapping, anterior shoulder pain and weakness, and it oftentimes is accompanied by rotator cuff tendon tears, which murky the diagnostic waters, making diagnosis much more difficult. Can you hear me in the back? We're good? All right. And to make things even a little more difficult, on arthroscopy, only 50% or about 50% of pathologically proven abnormal long hip biceps tendons are identified on arthroscopy. So they go in and it looks like a normal tendon. What will happen oftentimes, they'll make a presumptive diagnosis of long hip biceps tendon pathology based on the pre-surgical examination. And if they have if they have an abnormal anterior shoulder pain, they have a concern for a long hip biceps tendon pathology, they may remove it even if it looks normal on arthroscopy. And that's where imaging comes into play. Now, I found the MR and MR arthrogram as superior to ultrasound for the medial aspect of the biceps tendon. Here's the sagittal MR arthrogram, contrast in the joint, and you can see the interval here between the supraspinatus and subcapularis. This is the long hip biceps tendon, contrast oozing in. We know it's partially torn. Here's the corresponding arthroscopy, and you can see this is the long hip biceps tendon. It looks like a partially torn rope, and that's what it is. This is basically resected. Now, the correlation is not always as absolute. Here's another example: sagittal T2 weighted sequence, anterior and posterior. Here's the interval between the supraspinatus and subscapularis, and again, long hip biceps tendon with abnormal T2 signal within it. We presume tendinopathy, tendinosis, partial tear. In arthroscopy, it looks pretty normal. It's a little thickened, but otherwise it looks intact. And that emphasizes difficulty in diagnosing this tendinopathy, which oftentimes causes anterior shoulder pain from the interval itself. And therefore, oftentimes the algorithm in treating these is you presume the long hip biceps tendon is abnormal based on anterior shoulder pain with a rotator cuff tear. The surgeon will go in and perform a tenotomy, basically cutting the long hip biceps tendon at the origin, or phenodesis, where you cut the long hip biceps tendon at the origin and then reattach a distal portion to the humerus or pectoralis major tendon. So it's a difficult diagnosis to make, and treatment is often presumptive. Okay, now I mentioned the unusual course of this long hip biceps tendon, this sharp angle. What keeps it in the groove? Why does it not dislocate? What is the structure which holds it in place? And I mentioned the pulley. So that pulley is that sling-like structure formed by the thoracohumeral ligament, superior glenohumeral ligament, and fibers from the subscapularis. So you've got a medial component from the SCHL and the subscapularis here, and a lateral component from the lateral thoracohumeral ligament, and maybe fibers from the supraspinatus tendon. They all form a sling around the biceps, holding it in place. And here's the dissection we did of the pulley itself. This is the pulley here, dissected off the humerus. You can see the close association between this pulley and the adjacent tendon, and corresponding histology. Biceps would live here. See the multi-layered structure of that pulley, which holds the biceps tendon in place. In arthroscopy, you can see it as well with forward flexion of the arm. This is from the posterior portal. This is the elongate biceps tendon. This is the medial pulley. This is the lateral pulley. Here's your humeral head. Now, ultrasound is very good, as Professor Adler has shown, and showing the pulley itself. Here's the short axis of biceps tendon in the interval. Here you can see the pulley closely associated with the biceps tendon. Supraspinatus here and subscaps here. So ultrasound shows the biceps pulley very well as well. MR arthrography is really excellent at showing the pulley itself. Sagittal and axial MR arthrogram images. You can see the interval here. Here is the biceps. This is a portion of that pulley closely associated with the biceps. Axial as well. This is the biceps, and a pulley closely associated with it as well. Now, biceps pulley lesions or injury occurs when you have tears or injuries involving that far lateral rotator interval. So here's a coronal weighted sequence. Here's fluid where you can see the pulley. So it's a partial tear of that pulley laterally, and you can see there's also accompanying partial tear in the subscapularis as well. So when you have rotator interval tears, you'll expect pulley lesions and injury as well. And oftentimes they're accompanied by instability and tendinopathy of the elongate biceps tendon. And that's what makes clinical diagnosis of pulley lesions so difficult. What?
You don't see the mouth.
There it is.
You see it now?
Victoria Mani.
X'għati xinu miex ta'
Short intermission. I'll repeat the last 30 slides, okay? So we're talking about elongate biceps pulley lesions injury, and I've said oftentimes it's accompanied by elongate biceps tendon instability. And the patterns of instability vary according to the components which are injured. Here's a nice illustration showing different patterns of instability, but I'll show you a few examples. So here we have an axial and sagittal T2-weighted sequences, and you can see the biceps here's the bicep groove, and the biceps is mildly medially subluxed. It's not completely dislocated, has not completely left the groove itself. And when we look at the sagittal, we can appreciate a subscapular tendon tear, but the pulley is still intact, and that's why the biceps is not completely left the groove, but has slightly increased motion. Okay, that's medial subluxation. In this axial T2-weighted sequence, we can see a tear of the interval, a tear of the subscapularis. The elongate biceps tendon has dislocated into the substance of the subscapularis because of the combination of both of these tears. Another example in this case, an axial MR arthrogram, you can see the empty bicipital groove. There's intra-articular dislocation of the elongate biceps tendon following rupture of the subscapularis and of the pulley itself. Both these structures are gone, and there's complete dislocation into the joint itself. And here's another example, an axial T2-weighted sequence in an ultrasound. The bicipital groove is empty. The elongate biceps tendon is dislocated medially, but it is sitting on top of a partially torn subscapularis. The pulley is gone, the subscapularis is still partially there, and the biceps is sitting on top of it. You can see the subscap and the empty groove. Now, from a clinical perspective, again, as I've said, difficult diagnosis of pulley lesions because there's often accompanying elongate biceps tendon tears or tendinopathy. Here's an example, axial T2-weighted sequence, subluxation of the abnormally looking biceps, corresponding arthroscopy, partially torn biceps, and that's where the symptoms will come from. In addition, oftentimes there are associated rotator treatment-wise, it has not been shown that the relocation of the long biceps tendon and basically reconstruction of the pulley has any advantage over tenotomy or tenodesis, as there's a snipping of that tendon. So what we do in my institution is just do a tenotomy and tenodesis and don't try to reconstruct the pulley. But again, this may change over time. And here you can see an arthroscopic image. You can see the abnormal long biceps tendon. And this is part of the tenotomy where they snip that proximal long biceps as part of the repair. Now, I've talked about the anterior rotator interval. There's a less well-known interval in the far back of the shoulder, and it's called the posterior rotator interval. When you look at the supraspinatus and the infraspinatus as they diverge along the scapular spine here, they form a little triangle, again, devoid of tendons. That's the posterior rotator interval. Again, devoid of tendons in one muscle. And as the tendons extend laterally, they form an overlap area. The infraspinatus right over the supraspinatus, forming the overlapped area, part of that interval as well. I want to talk a few minutes about this area. So what do we know about this area, this posterior interval? Well, based on cadaveric studies from the 90s by Clark and Harriman, we know that this is a focally thin area. Based on ultrasound studies from the last 2 years, we know that degenerative type tears may begin in this area as well. And finally, we know that certain tears, including L-shaped tears, where's my mouse, may extend through this area as well. So this area, this posterior rotator interval, may be a potential weak area in the shoulder. But truthfully, we didn't know too much about it. In our clinical practice, what we noticed is that on MR arthrograms or MRs, we'd see fluid signal in a typical distribution, circumferential along the infraspinatus here on the sagittal T2-weighted sequence. And between the infraspinatus and supraspinatus, fluid signal here and here as well, oftentimes. And this fluid signal could be linear, as here. It could be crescented, or it could be cyst-like. And we weren't sure why this occurs. So we dissected some 7 shoulders and looked at that. So here you can see one of our dissections. And we, on histology, what we found is far laterally, as expected, that posterior rotator interval is really devoid of any substantial tissue, mainly connective tissue in the vessel. Corresponding ultrasound here. Here's the posterior rotator interval. The whole area has got this transverse layer perpendicular to the overlying cuff. Part of this is the cable, which I'll talk about later. So there's this layer transverse and deep to the cuff itself. You can see this in ultrasound and MR very well as well. Transverse layer, deep to the cuff, the area of the interval. We also found that the infraspinatus is formed of compact parallel fibers. As you can see, this is the infraspinatus here, compact parallel fibers. It's got a peritendinous sheet, and you can sometimes see it on ultrasound as well. So this is the infraspinatus, this is the peritendinous sheet, this is the supraspinatus with the fibers deep to the infraspinatus. And interesting enough, a lot of our H&E dissections, our slides show these clefts between the, where's the arrow? Second arrow. You see the arrow, right?
Yeah.
So we found these clefts between the peritendinous area and the infraspinatus, or between the transverse layer and the overlying cuff. And I think these cleavage planes may indicate there's a potential space here because it occurred on multiple slides as well. So our theory was that, degenerative tears occur far laterally. Fluid penetrates the tendon under pressure, as you can see here. Then it will dissect into potential spaces, for instance, in the peritendinous area here, or between the transverse layer and the overlying cuff, area of weakness, okay? And as it courses more medially where there's this loose connective tissue, it can form cysts. Now, what does this mean? What are the clinical implications? Will this indicate that the tear will propagate through that area? We're not sure at this point. What we have learned from this study is that oftentimes when we see fluid signal in the far medial aspect of the posterior rotator interval, not to call it tear, because on arthroscopy it will be a call. They will not see it. It's got intact cuff and cable basically deep to it and superficial to it. So we try not to overcall tears here, aware that fluid can dissect in this location and not be appreciated on arthroscopy. Now, I owe you an explanation. We talked about bridges. What has this got to do with our talk? And here I'll talk about the rotator cable. Rotator cable basically hangs between the anterior rotator interval and the posterior interval. So what is it? Well, it's a thick fibrous band starting at the interval itself here. It runs perpendicular to the supraspinatus and infraspinatus. It is an extension of the coracohumeral ligament. In histology, you can see it very well here as an bundle of fibers here deep to the cuff. Here it is here. This is basically the illustration showing the same. You can see it on arthroscopy as well. So this is the articular surface. This is the cable running from anterior to posterior, and here's the cuff perpendicular to the cable itself. You can see it on ultrasound in most patients from our experience. Here's a long axis view. You can see the supraspinatus inserting on the the great tuberosity, and this bundle here is that cable running perpendicular to the cuff itself. It rotates 90 degrees, short axis. This is the interval we were talking about, the anterior interval. This is the supraspinatus tendon. You see fibers running from the interval perpendicular to the cuff, deep to the IST, and finally merging with the capsule in the area of the teres minor. Same thing on MR and MRophogram. Coronal and sagittal weighted sequences. You can see the cable deep to the cuff itself, and when you return to the sagittal sequence, you can see cable deep to the supraspinatus and infraspinatus tendons concurrent. The cable can appear broad or narrow. That's absolutely fine. And here are a few examples of the cable in the context of cuff tears, which interests us. Here's the partial thickness articular surface tear, lateral and medial. Here's the SST. You can see a partial thickness articular surface tear here, but the cable is still intact. And here's a full thickness cuff tear in two examples. Sagittal T2 weighted sequences. You can see a full thickness defect of the far lateral supraspinatus tendon, but when we scan a little more medially, normal intact cable running through that tear. Same thing on ultrasound, focal full thickness tear, intact cable running from the interval deep to the cuff itself. And from our experience, most cases, the full thickness tears will not cause rupture of that cable. It will still be there. Okay? Most cases will have an intact cable in the context of cuff ruptures. However, in the context of cuff pathology, it may look a little different. It may look thickened with a heterogeneous signal, as it looks here and here. And in the context of cuff tears, massive cuff tears, we'll also see medial displacement of the cable. And we're not sure what it indicates at this point. Here's the medial displacement compared to the normal appearance of that cable-like structure. So again, what has this got to do with shoulders? Okay. So there's a group led by an orthopedic surgeon by Burkhardt who says that the cable provides stress relief or stress shielding to the cuff itself. Okay. Very much like a suspension bridge. So here's an illustration of a suspension bridge, and you can see the deck here. You can see the cable over here, held in place by two huge anchorage blocks. Okay? So it provides stress shielding to underlying deck itself. And here's an example of the largest suspension bridge in the world in Japan. It's about 2 kilometers long. It's massive anchorage blocks weighing 350,000 tons on each side, holding that cable. And here's another example of a suspension bridge. This is called the Silver Bridge in Ohio, and it's the first bridge where the cable is built of these eye bars. You can see, I hope you can see the eye bar here. And in 1967, this bridge spontaneously collapsed. And when examined, the cleavage fracture was found in the eye bar. So the reason for collapse was basically a cable failure. So we're thinking. Remember the first question I presented, when and why do symptoms occur? One of the theories out there has to do with the cable. Maybe it has to do with the cable. So there are a lot of studies looking into that. This is a small study from our group where we basically retrospectively looked at 24 patients who had massive tears, treated conservatively, no surgery, had some physiotherapy, looked at the cable position, the cuff, the atrophy, and so on. And also had them fill out questionnaires, multiple questionnaires, indicating what function they have, pain, limited range of motion, and so on. And what we found is that tears extending to the medial rotator interval are oftentimes associated with inferior outcomes. So tears going to that anterior interval have inferior outcomes. So again, why? Why would that occur? Our theory is this. You have a tear extending from the cuff into that interval, basically disrupting the connection between the cable and the anchorage block. You've lost that connection to the cable. You cannot have stress shielding. It's a theory out there. There are a few studies indicating the same. There's a study by Bernard looking at pseudoparalysis, cuff tears with inability to lift the shoulder, and indicating that involving that cable anchorage is very important. And in 2012, the American Academy of Orthopedic Surgeons had indicated in the context of cuff tears, adequate fixation near the rotator cable attachment is So in summary, I've talked about the anterior rotator interval, okay? We talked about stability of the shoulder joint as it relates to the anterior rotator interval and loss of motion, adhesive capsulitis as it relates to anterior rotator interval. We've talked about the pulley in the interval and how it stabilizes the elongated biceps tendon from dislocating or a subluxing. And finally, we talked about rotator cable, that fibrous band running deep to the cuff itself, maybe providing stress shielding and acting as a suspension bridge, okay? And